Bonjour à tous. Cette vidéo nous présente les facteurs de risque et les moyens de prévention de la maladie thromboembolique veineuse après chirurgie hépatique.
These are my disclosures and my disclaimer concerning this presentation. My goals in the next few minutes will be to review the VTE and bleeding risk in liver surgery. The second one will be to review the time course of the disease and the extended thrombotic risk. And finally, to summarize data on the results of pharmacologic thromboprophylaxis in liver surgery with a special attention to its duration. The clinical practice guidelines have systematically reviewed over the last 30 years the evidence from numerous clinical trials and concluded that appropriate use of VTE prophylaxis in postoperative patients is safe and effective. However, the overall incidence of VTE is still high. Concerning general surgery, asymptomatic VTE rates without prophylaxis in patients without prophylaxis ranges between 15 and 40%, and in patients with symptomatic VTE is around 2%, ranging from 0.5 to 6%. In every patient that we have to operate, we have to assess the risk of thrombosis and the risk of bleeding. Concerning the thrombosis risk assessment, we have several risk assessment models. The most extensively used and validated is the Caprini score, but also we have another RAMS, but the problem with these RAMS is the lack of external validation. Concerning the bleeding risk, we have a very few studies. Most of them are based on expert opinion, and classically they divide into patient-specific and surgery-specific risks. This is the Caprini Caprini score, as you can appreciate in the slide. It has been validated in several surgical specialties. Obviously, general surgery is one of them, and obviously it can be also applied to liver surgery.
Le score de Caprini a été validé dans de nombreuses études. Néanmoins, il est difficile à mettre en œuvre au quotidien. Il donne beaucoup de poids à la chirurgie, alors même que les techniques chirurgicales et les parcours patients évoluent. J'utilise volontiers les facteurs de risque et algorithmes définis dans les propositions du GIHP, le groupe d'intérêt en hémostase périopératoire.
Concerning general risk factors, we can appreciate in the left side of the slide. These factors, I won't take this because it's a part of another presentation. But concerning the surgery-specific bleeding risk in liver surgery, the bleeding risk is increasing depending on the number of segments resected, depending on if we have to resect extrahepatic organ resection, depending on the primary liver malignancy. Also, if we have a lower preoperative hemoglobin level, platelet counts. But in my opinion, we have also to see that we have a liver-specific bleeding risk. In my opinion, by definition, the liver surgery is a bleeding risk, because if you cut the liver, it bleeds. This is obvious. The bleeding can start when we mobilize the liver. So the liver is attached to the diaphragm and to the inferior vena cava. If we mobilize, if we do a hole in the inferior vena cava, it can be fatal for the patient. Obviously, we have also to take into account the underlying liver disease. It's not the same to operate a normal liver, for instance, patients with an adenoma, that we have to remove hepatocellular carcinoma in a patient with a cirrhotic liver and portal hypertension.
L'hypertension portale est un facteur de risque important de saignement et de morbimortalité post-opératoire en chirurgie hépatique.
In patients that with colorectal liver metastasis, for instance, in which we use the chemotherapy, we have to take care because some monoclonal antibodies increase the risk of bleeding. We have to take our time from the last cycle of monoclonal antibodies until surgery. We have to wait 4 or 5 weeks. We also have another problem with the jaundice, with the yellow livers. Okay, imagine that we have a hilar cholangiocarcinoma in which we have an obstruction of the bile duct. with an increased bilirubin levels that they provoke a coagulation disorder. Obviously, we have to correct this before the operation.
L'hyperbilirubinémie diminue l'absorption intestinale de la vitamine K et entraîne un trouble de la synthèse des facteurs de coagulation vitamino K dépendants.
Obviously, to finalize, if we have a vascular recession, if we can appreciate in this picture, in which we remove the inferior vena cava and we put a prosthesis, obviously the risk of bleeding is higher. But what is the BTE rate following an hepatectomy? This is a very interesting paper by the MD Anderson, published last year, in which we compare the BTE rates, comparing open versus laparoscopic hepatectomy after and before a propensity score matching. So prior to matching, the BTE rate was higher in the open hepatectomy than in laparoscopic hepatectomy. But if we after the propensity score matching, it is still higher, the BTE rate after open hepatectomy than after a laparoscopic hepatectomy. Not also in major hepatectomy, but also in minor hepatectomy. This is how we can appreciate the number of BTE events in this picture. The risk of BTE outweighs post-hepatectomy bleeding complication. This is another study by the University by the MD Anderson with almost 6,000 hepatectomy. This is the complication rates of BTE events is almost 3%, compared with the postoperative bleeding events is less than 1%. And this BTE risk increase with the magnitude of the hepatectomies as we saw before, and also with the outnumbered bleeding events during hepatectomy. But the most important messages of this paper is that BTE resulted in a 30-day mortality of 7.4 versus 2.3 with no BTE. This is very important message for this from this paper. And maybe the next question is to check if pharmacological BTE is safe. And this is a very nice systematic review from my colleagues from Manchester, in which they include patients receiving chemical thromboprophylaxis, and they compare with patients that only have mechanical prophylaxis. This meta-analysis revealed that lower BTE rates in patients receiving chemical thromboprophylaxis 2.6% compared with patients without prophylaxis 4.6%. The most wide heparin administered used in this study were the unfractionated heparin and obviously the enoxaparin. So perioperative chemical thromboprophylaxis reduced the BTE incidence without an increase of risk bleeding.
Il est maintenant recommandé de privilégier les héparines de bas poids moléculaire pour la prophylaxie pharmacologique et de ne réserver l'héparine non fractionnée qu'aux insuffisants rénaux sévères. On ne sait pas ici quelle était la prophylaxie mécanique utilisée, bas de contention ou compression pneumatique intermittente. Les bas de contention n'ont aujourd'hui plus leur place, sauf si le patient présente une insuffisance veineuse préexistante et qu'il porte des bas de contention à domicile. La compression pneumatique intermittente peut être associée à la prophylaxie pharmacologique en cas de très haut risque thrombotique.
What we have to do following discharge of the patient, this is very clear in this slide from the National Comprehensive Cancer Network. In patients, it is in patients with high risk of abdominal pelvic cancer surgery patient, we have to do this prophylaxis up to 4 weeks after discharge. This is another interesting paper again by the MD Anderson with 124 patients. Once they do the hemostasis was assured following the hepatectomy, they initiate the anticoagulant BTE prophylaxis for the hospitalizations, and they continue this thromboprophylaxis with enoxaparin after up to 14 days after a laparoscopic hepatectomy and up to 84 days after a major hepatectomy or a previous history of BTE. And this is a very nice number. They don't have any BTE even in the postoperative time of these patients. This is an interesting slide. This is an interesting study. So according about what we HPV surgeons do after the discharge of the patient, this is a survey of HPV fellowship training programs in the USA and Canada, and we only do chemoprophylaxis after discharge of the patient in 77% of major hepatectomies, and after minor hepatectomy only 55%. So the use of chemoprophylaxis following discharge after HPV surgery resection for cancer was only moderate among HPV surgeons. So we have to change these numbers because the data are really clear. No?
La chirurgie hépatique carcinologique fait partie des chirurgies abdominales majeures. La thromboprophylaxie pharmacologique doit être prolongée 28 jours, même après chirurgie laparoscopique, même en parcours RAC, c'est-à-dire réhabilitation améliorée, accélérée après chirurgie.
Another interesting question is when we have to start the chemoprophylaxis in liver surgery, pre or post-operatively. This is a very interesting paper from the University of Helsinki. It was published last year, comparing two groups. The first one, they initiate preoperatively the chemoprophylaxis with enoxaparin the previous evening of to surgery, compared with another group in which the start the chemoprophylaxis again with enoxaparin depending on the weight of the patients 6 hours after surgery.
Les recommandations européennes ou françaises ne vont pas dans le sens d'une première injection préopératoire. Des études suggèrent même de décaler l'initiation à 8 à 12 heures post-opératoires en fonction du risque hémorragique de la chirurgie.
And it is very clear that the incidence of BT was significantly lower in the preoperative group compared with the postoperative group, 1.2%, compared with 9.7%. And if we can appreciate here, the postoperative hemorrhage level rates were almost the same. So initiating thromboprophylaxis preoperatively may reduce the incidence of postoperative BTE without increasing the incidence of hemorrhage. So what are the predictors for pre versus post-discharge BTE after hepatectomy? This is another study from the MD Anderson group with almost 8,000 patients. There was these are the even rates of BTE, almost 3%. We have an interesting data here that almost 30% of the BTE occurred after discharge of the patient, and this BTE was associated with a longer operative time, longer than 4 hours, with an organ space infection, with a return to operating room. So to summarize what the guidelines say about we have to do with this patient, this is very clear. We have several guidelines, but the message is the same in everyone. After a surgical intervention, most important if we have a cancer, the thromboprophylaxis with low molecular weight heparin is mandatory. And the most used in this heparins are enoxaparin with difference, and after that the deltaparin. And to summarize, what are the recommendations in liver surgery? What we have to do if we have a patient that we have to do a liver resection. Before the hospital admission, we have to do a full history and physical examination of the patient. We have to assess the thrombosis and bleeding risk. During the hospitalizations, we have to start the preoperative prophylaxis if indicated. Intraoperatively, we have to try to decrease the operative time. We have to use the laparoscopic approach if feasible, and use the mechanical methods as we can appreciate here in this picture. Postoperatively, we have to start the early ambulation, the first day if feasible, and we have to start the chemoprophylaxis with low molecular weight heparin as soon as possible. And after discharge, for sure, we have to start chemoprophylaxis in high-risk patients. To finish, we can say that postoperative VTE after liver surgery can be a devastating and obviously a costly complication. Current strategies are unable to eliminate the risk of VTE. The use of mechanical or pharmacological prophylaxis is safe, is effective to reduce the risk following liver surgery, and this benefit needs to be carefully balanced with the potential harm of prophylaxis. The full risk stratification is therefore crucial to determine the optimal VTE prophylaxis strategy.
Il est important d'avoir des stratégies et des protocoles d'équipe et de tracer les décisions médicales dans le dossier du patient.
Thank you very much for your attention.
En conclusion, la chirurgie hépatique peut se compliquer d'événements thromboemboliques veineux post-opératoires, même après la sortie du patient de l'hôpital. Une thromboprophylaxie pharmacologique doit être initiée dès la 8 à 12e heure post-opératoire, de préférence par héparine de bas poids moléculaire, pour une durée totale de 28 jours.